We're rolling. Welcome back, everybody, to Ad Hoc with the Doc. And I'm here with my very dear friend and colleague, Dr. Paul Mittman. As you know, Ad Hoc with the Doc, our talk show every 2 weeks out of Naturopathic Specialists here in Scottsdale, Arizona. We have a really interesting topic to talk about today, which is basically called, it's disruption in healthcare. And Dr. Mittman is probably the most well-versed, I think, to talk about it. And so I'd love to just kind of launch right in. So let's talk about explaining what disruption really is, how it's defined, and talk about examples that outside of medicine before we launch into examples inside of medicine. So just for the audience may understand examples a little bit outside of medicine, other industries that they're familiar with.
Yeah, well, I should say at the outset that I cannot take any credit for the whole concept of disruptive innovations. And so just for a little bit of background on it, there's a professor at Harvard, his name is Clayton Christensen. And he is not just a professor at Harvard, but he's won the McKinsey Award more than any other author, which is the best article in any given year in the Harvard Business Review. And he started writing about disruptive innovations about 20 years ago. And you could see speeches by him on it. It's really a fascinating topic. And the idea is that innovation rarely comes from the dominant player in an industry.
Why would they need to disrupt? Maybe at one time they were disruptors.
Right, and their improvements they're always getting better, but it's always incremental. It's not like a sea change. And so, classic example is in the computer industry. I remember that the computer that was used when people went to the moon had less computing power than are in any of our phones now. So a computer that used to be a mainframe computer took up like an entire room or this entire office, and 10 years later, or in the 1970s, they come along with mini computers, which are the size of a refrigerator.
And the joke is, at that time, the computing power, your phone would have cost like $3 billion at that time.
Right, and so the mainframe computer costs a ton of money. You need like a whole team of people to run it, and then along comes this little thing, relatively little, a mini computer, you know, the size of like a refrigerator, that says, and a company like Digital Equipment Company, was a big company in the 1970s, and they say, we could do most of this, but not all of it, but for a lot less money. And the mainframe companies were like, you can't hold a candle to us, but they did enough jobs well enough for less money. And then the desktop computers came along and displaced or disrupted the mini computers. And a company like DEC, which was one of the biggest companies in the United States, goes out of business.
I mean, who would have thought at the time that you would have that kind of computing power right here in front of you at the table?
Or in your hand.
That's a disruption.
So that's a classic disruptive innovation where the dominant players are so invested in the complexity and the cost and everything that goes into their product that to scrap something like that for something that costs less, that frankly doesn't do it. The desktop computer didn't have the computing power as a mini computer, but it had enough to do word processing or spreadsheets, and gradually, each one's been disrupted. So fast forward to 2003, Clayton Christensen writes an article about disrupting U.S. healthcare. There's an article in the Harvard Business Journal.
Let me ask one question. Yeah. Does disruption necessarily require innovation? Because I'm wondering, as we're going into healthcare, if we need to keep that in mind as we listen to you.
Well, the idea of innovation, when we usually think of innovation, oftentimes we think of you have to create or you have to completely invent something.
Okay.
But innovation could just mean doing the same job less expensively.
Indeed. Okay.
Or quicker.
Thank you. So let's keep that in mind, that in terms of innovation, it doesn't mean something brand new that we've never seen before. It's maybe a better way to do something or something that's more efficient. In terms of medicine, let's find out.
Well, so he writes this article in 2003, and he says, I predict that medical doctors, particularly in primary care, are going to get disrupted by a less trained and less expensive practitioner, and
Still qualified. Still
qualified, didn't go to medical school, didn't do residency, and lo and behold, he was predicting that nurse practitioners and PAs were going to capture a huge market share within primary care.
as the first line that the patient is going to see up front for something acute or even something chronic.
Yeah,
At a family practice level.
And it's not like like a medical assistant where the doctor is going to come in, you know, like the medical
Correct.
assistant is going to do the vitals, and then the doctor is going to come in and do the real work. It's the PA is going to do the whole visit, or the nurse practitioner is going to do the whole visit. I was in the emergency room a year ago, and I saw an MD for about maybe a minute or 2 minutes, but all of the work, the suturing my head, the history, the physical exam, ordering lab work, that was all done by a PA and a nurse practitioner. Why?
Who would have thought, especially in an emergency setting, that
Yeah.
you would see that?
Right.
I mean, I think there's expectations out there that the audience has, is that when you go to the doctor, you're going to see the MD. You now go to the doctor's office and you might not see the doctor. You may see somebody who's considered a physician extender.
Yeah, a lot of people never see a doctor.
So this
you
is
go
a
and you see a PA. So that's a disruption where it's not necessarily, they're doing pretty much the same work, and you could make the case that, you know, that in a very complex situation, you would want the person who is boarded in a particular specialty area, but for most of the reasons that people go to the doctor.
What were you doing in 2003
You don't need that.
when this prediction was being made? Dr. Christensen was making the prediction. Dr. Mittman, where were you? Where were you in practice or in administration? We should say current position. Dr. Paul Mittman is the president of Southwest College of Naturopathic Medicine and Health Sciences in Tempe, Arizona, my alma mater, which is where I met Dr. Mittman. But what were you doing in 2003?
I was president of the school.
Still, so that was 14 years ago.
Right, and so when I read that book, it got me thinking, number one, there are a lot of things that NDs, that us as naturopathic doctors, have been doing for a long time. And we're the best when it comes to nutrition and lifestyle and making those kind of changes. And if we're not careful, we'll get disrupted. And we have been. We've been disrupted by health coaches.
Okay.
Less trained. Well, they don't have the training that we have. But you know what? For a lot of people, it gets the job done. And so you have health coaches either practicing on their own, or you have people actually practicing in doctors' offices to offer this service.
I think the problem that some people have is that do lesser trained practitioners know where their limits are?
That's really the rub. Okay. So the other thing that I was thinking was, well, if ultimately we're going to get disrupted, where are the places that we as naturopathic doctors can be disruptive? Where are the parts of the market where we could do something either better than anybody else, or we could offer something that's less expensive than a place that has tremendous overhead.
So our naturopathic doctors, are we disruptive? Are we innovating? Are we coming in? Are we new entrants? Are we old entrants but entering into a new area? And do we have a question?
Yeah, we have a question that was written in earlier that kind of goes along with where you guys are at. It asks, what healthcare problems do you see that have unmet needs or can be delivered less expensively or more conveniently?
Well, this goes along with that question.
Yeah, absolutely.
Are naturopathic doctors disruptive?
Right. And if we're not, and if we just hold to, because naturopathic medicine's been around for over 100 years now, and there's a lot of tradition in naturopathic medicine, but if we cling to this image of naturopathic medicine as if it were like in a Norman Rockwell painting, then we're not going to survive very long in the 21st century. So, classic example
Okay.
is that we have millions of women who go into perimenopause and menopause and are written prescriptions for essentially the same dose of estrogen and progesterone. And
Doesn't matter how their body mass index or their percent body fat or their size.
but there are
the
risk
same-
factors for cancer, or heart disease, or other conditions. And it's
Or
a
their
one size.
genomics, or their metabolism, or looking at pharmacogenomics. Is what
Right, and so the dominant field there is a gynecologist. I mean, that's who the woman is going to see, is a gynecologist. And you have naturopathic physicians who are offering, and I would say, I'm very proud of the education that we both received in naturopathic medical school and that we offer it at Southwest College. But the number of years of training for naturopathic doctor, 4 years of medical school, and for some people who've done residencies, a year, 2 years of residencies, is frankly less than a gynecologist or someone who's board certified in that area. And yet, at the same time, we can offer something, let's say in this particular patient population for women who are going through menopause, we can offer them personalized care.
Yes,
We can tailor it.
But does it matter the length of time of the training or the concentration of the training? Because we had an ad hoc with the doc, with Dr. Stefanski, where we talked about naturopathic doctors help pioneer the use of bioidentical hormones,
Right.
which, from a pharmaceutical standpoint, that was really neglected by the standard gynecologists out there who were giving maybe the branded estrogens or the horse urine. We had a whole ad hoc with that. If you want to look at it, it's archived. But why would naturopathic doctors be able to give hormones with maybe lesser years of training? It's because of the concentration and the type of training that we give. And we may be more authorized to utilize those hormones, like you said, on an individualized level, because of the way we look at the body. We're naturopathic doctors.
Right.
We look at it differently, and therefore individualized prescriptions. Would you agree that that's a disruption?
Yeah, well, that's disruption, and I would add to that from the get-go, I mean, as NDs, we learn pharmacology, we learn minor surgery, so we have an appreciation for the use of prescription drugs
Sure.
when necessary, but from day one, the use of whether it's bioidentical hormones or herbs or nutrients is built right into the kind of the operating system of who we are as naturopathic doctors.
As president, you must be very keen on the subject of disruption and disrupting. But I would say they're central to helping enroll students and pointing students as they graduate to residencies or seek jobs. Where's another area besides, say, gynecology? You mentioned urgent care. There have been some, I would say, innovations in urgent care with naturopathic physicians.
Yeah, I remember, Doctors Walker.
One of my classmates.
Sam and Kathy Walker started an urgent care, a naturopathic urgent care in 1998.
First of its kind?
First of its kind anywhere. They don't take,
In the U.S.
before there were urgent cares, actually. No appointments.
What was their background before naturopathic?
So they were both ER nurses. So they had this...
Which is who you saw... I'm sorry, ER nurses. That wasn't who you saw in the ER.
Right, no,
Back up.
So, that was their background, and I remember at the time it was really novel. I didn't know any NDs who were doing it, and frankly, I didn't know any MDs who were doing it either. Their idea was that, we're going to put ourselves, and this is a disruptive innovation, because they put themselves, like, if you were to do like a practice management class, and they were to say, well, you should look at like the zip codes and the median income for the, for this particular area. They put themselves not in a totally impoverished area, but in a low income, underserved community for people who either were underinsured, or probably some of them didn't have access to insurance. They had a flat fee. It was like, I think, $45 a visit. New patient, return patient, but they would see like 70 or 80 patients a day. And they developed a system there where they used residents. So they've had residents for many years. And in that community, they became kind of the bedrock of healthcare for a community that otherwise, for a variety of reasons, didn't have access to healthcare. So now there are 5. They didn't start other ones, but we know of other NDs who I can think of 5 in the Valley who have based the same model. And in fact, just a couple of months ago, my son got hired at one of them, and they've been in operation for 6 years. They have 20,000 active charts.
20,000
active charts. Like he got there right around, it was either 20 or 19. They hit some kind of milestone there. And so I was thinking, one time on a weekend, I was sick.
Yeah.
Laura goes, you've had that stomach ache for a couple of days. And we're both doctors, so it's like in my mind, I've got pancreatitis, I'm having a gallbladder attack, I'm like no more coffee, no more anything. And she goes, you better go like to urgent care or something. And so I thought, I'll go to one of these places. So I went there and I walked in at 10:10 in the morning. There were 27 people in the waiting room.
10:10 in the morning.
Right, on a Saturday. And they took new patients till noon. And it was probably like, some of them were like parents with a kid or, a wife with a husband or something like that. So it probably wasn't 27 patients. But 45 minutes later, I had an appointment and I had a really good visit. And it wasn't like it was just NDs doing allopathic care. They did hydrogen breath tests and they looked for, things that were unique from a naturopathic.
It's urgent care with naturopathic medicine built in.
I would say it's urgent care with a naturopathic twist. Or naturopathic
Which
flavor.
is really important because one of the disruptions that you and I have talked about, I think, would be in the dermatological aesthetics realm. And there have been, I know, and you of course know better than me, but just from being out in the field and having colleagues, that there are places where naturopathic doctors are practicing aesthetic medicine, but because of their training and where their heart is, and they're graduates of naturopathic medical school, they might also talk about diet and how it relates to skin, or certain detoxification elements, or avoidance of certain toxins that are known to damage skin. Or we're not even going to get into environmental medicine right now. That's subject for another episode. But would you consider that a naturopathic physician taking advantage of being a disruptor?
That is a classic disruptive innovation.
Talk about that.
Well, think about like 25 years ago, like a comedy routine would talk about like an actor and actress who had work done, so like any kind of like, work done, to like, get rid of wrinkles or whatever. The only person qualified to do that was a plastic surgeon.
Indeed.
And like the training, and really, and I say this with tremendous respect, the training for a plastic surgeon, not just residency, but surgical residency and the plastic surgery fellowship is very extensive, very expensive, very exclusive.
And at the time, work done was surgical.
Yeah, it was surgical, or, but even when Botox first came out, it was first the domain of a plastic surgeon. Botox, Restylane, liposuction, for example. And so the plastic surgeons, were the first. And then after a while, you started seeing it at dermatologists' office.
Right.
Dermatologists are highly trained, and I would say, very high on the pecking order as far as specialists are concerned. Very hard to get into, very expensive. And then after a while, you had MDs, just in general, providing aesthetic services.
Somebody who
Botox,
may have been in a different specialty, but moved over to provide.
Or family practice, for that matter. But I mean, if this is what they really had a passion for, then good for them. Or maybe it was an add-on to their practice.
Sure.
And then, over the last probably 10 years, NDs started doing it. And this is like one of our, a friend of mine who works for a bank was meeting with a plastic surgeon. It's like, what's up with these NDs? Who do they think they are?
Who said that?
The plastic surgeon
Comes into
was saying to my friend who does banking and finances, helps finance clinic growth and things like that, and was talking to a plastic surgeon, and he's like, who the hell are these NDs? I have all this training, I I'm boarded in plastic surgery, I've got this and this, and who are these MDs? And he was referring to a practice, I'm not going to mention the name of the practice, that has they are the largest Allergan, which is Botox, Allergan account in Arizona, and it's a multi-site practice, and they employ exclusively NDs as their doctors. And so that's a classic disruptive innovation, where you have people who are well-trained, but don't have as many years of training, but who are really good at what they do, and they're good enough. They're not doing facelifts there.
But again, many years of training, it depends on what they're being trained for. And it sounds like the disruptee, or that who is disrupted, usually probably has a response like that one who was disrupted had,
yeah.
because it's disrupting an industry. I'm sorry, we have another question coming in.
Well, and it's less expensive. I mean, that's why, ultimately, that's why you're doing it, because, I mean, just frankly, it's less expensive to hire an MD to work in an aesthetics practice than it would be to have a plastic surgeon or a team of plastic surgeons working at each one.
Well, I think in general, we're starting to see the public understanding that there's value in investing their own dollars outside of what they pay for insurance into healthcare, which they may not be satisfied that they're getting at their insurance-based physician, or for an aesthetic procedure or something that's voluntary that's not necessarily covered. I think there's different stringencies on what is covered, and you're starting to see dollars move more into the non-third-party reimbursement sector. But sorry, not to delay the question coming in.
Yeah, Chris asks, what about personalized medicine? How does naturopathic medicine fit with this new chapter in medicine?
Personalized medicine. I mean,
I should let you answer that, because we're here at Naturopathic Specialists,
yeah.
and really the whole premise for Naturopathic Specialists is personalized medicine, and you started this particularly with oncology. I remember years ago, I mean, literally like 15 years ago, before anybody used the word personalized medicine, I remember patients having tumors removed, you guys isolating tumor markers and developing specific treatments based on their tumor markers.
Well,
that's like a classic example of personalized medicine.
So it's true. So personalized medicine, really in the era of what we could also say is precision medicine, because sometimes they're interchanged. In this office, yes, our tagline is personalized medicine, personalized care. It's really, the disruption there is based on each person as a true N of one. And the fact is that somebody can have their standard coded diagnostic, but that doesn't mean that they, in the world of oncology, that they got the cancer the same way as the next person who comes in with that same diagnostic code. Different life circumstances, a different histological or different pattern that you see under the microscope. Each of them could be, say it's somebody with breast cancer, could be estrogen receptor positive, but there could be different levels. Somebody could be 5% estrogen receptor positive, the other one could be 95% estrogen positive. And how do you go about treating that person differently? That's a personalized medicine approach. We are now in the era of genomics. At this point, most doctors are talking about genomics. In the family practice world, it might be pharmacogenomics. What medicine are you going to prescribe? And now dosing matters. You brought up the fact that every woman was generally women would get the same dose. It's still true that if in the world of breast cancer, if you go on, if you're postmenopausal and you go on an anti-estrogen drug after your standard conventional treatment, you are getting a standard dose. To my knowledge, I have not run into an incidence where it matters on your weight, your body mass index, your size, your pharmacogenomics. It's a standard dose. And yeah, I think that's problematic because it's not individualized. Conventional medicine is in oncology, is a very big vehicle that it moves relatively slowly when it comes to individualized medicine, but it does move in big leaps when it does move. It's gaining speed. There have been tremendous innovations, and some of the disruption in oncology now is more looking at the immune system, immune-based therapies. Small molecules came into being. So we've seen a great disruption in which pharmaceuticals are being produced, and in my opinion, there's less chemotherapeutics innovations than there are small molecules or specialty molecules that they seek out special targets on a cancer cell. in the naturopathic oncology clinic like this one, in my part of the practice, which is oncology, the personalized part is about trying to assess the person's unique physiology and figure out, for instance, how to make the blood less hospitable to, say, cancer cell survival, which, the blood is going to be delivered to the tissue, which is ultimately where most cancers live anyhow. And so in the era of personalized medicine, it's a huge disruption because it's complexified and it's disrupted general medicine because you have the internet, so you have savvy consumers who are now asking questions that, to a lot of physicians, they're not able to be answered. And we see a lot of people who are becoming dissatisfied with some of their practitioners because they can't get down to the personalized level. Why? The system doesn't provide for it. In general, I'm not saying in certain instances, but in general, they don't provide for the personalized approach, whether it just be that the clinics are too crowded or they're not referring to naturopathic medicine, because we are all about individualized medicine. It's part of our code, so to speak. It's a great question. It is a big topic, and maybe that's another ad hoc topic, is what does personalized medicine mean? What does precision medicine mean? Because that's sort of a subtopic of this.
And I would say not that everything in the world has to fit into disruptive innovation, but a practice like this, when it comes to either personalized medicine or precision medicine, is disruptive in that this is a really beautiful practice, but this isn't the palace that is, the oncology wing of the hospital with a proton accelerator, and so when we think about either personalized or precision medicine, we think about like the most high-tech and expensive approaches that spare no cost, and yet what you offer, but other naturopathic oncologists also offer is looking at the same evidence, the same terrain, and saying, well, what does this mean in terms of what you're going to be eating? What are the natural compounds, either that come from plants or that come from nutrients, either that we take
That's a disruption.
or supplements? That's a disruption because you're doing it at literally a fraction of the cost.
And it's with things that people need to do every day anyhow.
Right, because if you do this piece without what you're doing, well, then you're missing a big part of what's going to help a person get healthy.
Naturopathic oncology in itself is a disruption.
Yeah, right.
Do we have another question? I'm sorry.
Yeah, we do. Mandy asked, it's a little off topic, but it is relevant for the time. She asked, thousands of people are dying each year because of opioid addiction. How does naturopathic medicine address this?
I don't know that I'm qualified to talk about that. I don't know if it's really on.
I'm president of the school. I can talk about all kinds of things. I've told people that if you woke me up at 2 o'clock in the morning and asked me to talk about either Southwest College of Naturopathic Medicine or about naturopathic medicine, it would only take me about 3 seconds to launch into something. But this is actually
Perfect.
It's interesting because for years at SCNM, we've had a required course in addiction. I don't know if you knew that.
I didn't know.
So for about 10 years now, we've had a required class in addiction. And the college has 9 community clinics where we offer either free or reduced care cost.
9 clinics?
9. So Hamilton Elementary School, Sojourner Center for Domestic Violence, Southwest HIV/AIDS. Some of them we run, some of them.
Excuse me, that's a disruption in itself, I have to say, in terms of.
For those communities, yeah. So 3 of them have to do with drug and alcohol. And so at one point I thought, I should go visit. And find out. As a president of the school, I should visit and find out what's going on there. And we have a group of NDs. So over the last year, I started visiting some practices, some that are affiliated with the school, but some that aren't. I met a group of doctors who are in Arizona City who practice at a residential drug and alcohol program. They're the only they have a medical doctor there who's required to prescribe Suboxone and buprenorphine, the medical assisted therapies. but all of the clinicians there, they have 4 clinicians. They're all NDs.
That is
And
amazing.
so what they're doing is, from a disruptive standpoint, is you have the kind of conventional suite of treatments for drug and alcohol addiction. So you have 12-step program, you can have medication-assisted therapy for opiate addicts, you have cognitive therapy, but the NDs are giving people IV treatments, so IV nutrition. So when they're going through withdrawal and have diarrhea and vomiting, and they're dehydrated, and they have electrolyte imbalances, they're replenishing them.
And that just helps make the brain work better and the body
That's
work
like
better.
the dehydration is
basic.
right. The
I mean, that's not
dehydration.
happening in other.
Well, the dehydration is like basic kind of kind of thing. But
Yeah.
what you're talking about is like the next level. That's the naturopathic part. Is that from a disruptive standpoint, more than half of addicts end up taking antidepressants and anxiolytics because their brain chemistry,
Yes.
after many, many years, whether it's serotonin or especially dopamine, is just completely disrupted.
You know what the real question is? Why is that type of thoughtful, straight up physiological medicine considered a disruption? Why isn't that just what it is to begin with?
Well, at one
It's
point,
not-
like
it's a rhetorical
washing,
question.
at one point, washing your hands was like,
Yeah.
a disruption. Somebody started doing this, a doctor here in town, and now there are several, not that many, but there are several practices that are doing this. And so you started to get on this point about, brain chemistry. So in addition to, minerals, vitamins, lactated rumors, things like that in the IV, they started adding amino acids. And so the bulk of the neurotransmitters are called monoamines, and so that means that they're based on amino acids, so serotonin from 5-hydroxytryptophan, dopamine from tyrosine, and so from a naturopathic perspective, rather than using a drug to prolong, let's say, the presence of a neurotransmitter in a synapse,
Make more.
here, we're going to give you more
Let the body
substrate
do
so
it.
that you can let the body do
That's
it.
the vis medicatrix naturae. It's the healing power of nature.
Yeah.
It's treating the person.
And it's
Instead
a little
of
bit
blocking
high
it,
tech
yeah.
because you're doing it IV.
Pretty high tech, but it's sort of
But-
like, duh.
Yeah, so
That's an innovation. That's a naturopathic doctor that that you saw rise to this challenge meeting and now is successful. And you've helped usher so many people to be successful in their career through the school and help, in success out of the school. I know from a time perspective, we need to start wrapping this up. There's no more questions coming in. Dr. Mittman, I want to say thank you for being
my
here.
pleasure.
Any last thoughts or closing comments about disruption in medicine at all, or have we already sort of talked about everything you want to say?
I would say that when it comes to disruptive innovations, this is something that is happening in healthcare. It's happening in other fields also. But if there was one takeaway, it's that an innovation doesn't have to be coming out of Silicon Valley.
Yeah.
An innovation is just, like you said, the healing power of nature. Eating a certain way, mindfulness, exercise. You add all of those pieces, and those by themselves. I mean, mindfulness is another.
Yeah, there's
another
a brand new
type of
program.
disruption.
There's a brand new department, I think, at ASU about mindfulness and
Right.
giving and stuff, and that's maybe a topic for another day. But thank you very much for taking
My
time
pleasure.
out to be here.